Okay, so that was lymph nodes on ultrasound. We're going to start having a little look at the appearance of our lymph nodes on MRI. So unlike a lot of pathologies and structures, MRI actually isn't the gold standard for lymph nodes. I know we always go on about MRI being the gold standard for lots of different illnesses and MSK and neuro and soft tissue, but actually unless a lymph node is enlarged, it can be actually quite difficult to see it on MRI, and that all comes down to the thickness of the slices. So unless the lymph node is enlarged and therefore potentially abnormal, it can sometimes be tricky to see it on the image. So you can assess them on MRI. The size and the shape is less reliable, but if there is a loss of that fatty hilum, and if it's an irregular shape, then that is a bit more indicative that there is a malignancy. We obviously have to take into account the patient's history. So if the patient has night sweats, loss of weight, all the things that we talked about in the first part of this talk, and they also have an enlarged lymph node, then obviously that's suspicious of malignancy. Now it is important to note that MRI, because it is so sensitive, can have a false positive essentially. So the increased sensitivity means that they might find, for example, if someone who's got a primary breast tumour, they might see a lymph node that looks suspicious or enlarged on the imaging, and then they have to then go and get a biopsy of that, and it might be that that's quite an invasive process to have a breast biopsy, so it might be that that was unnecessary because there's a false positive or there's increased sensitivity. Normal lymph nodes, as I say, they might be too small to be seen because if the thickness of the slice is big or not as small as a lymph node, then it can be missed. Anything greater than 10 millimeters, so 1 centimeter, is suspicious of metastases. So that's quite similar to ultrasound. It seems to be, as they get up to that 10 millimeter, 1 centimeter mark, then you start to be a bit more concerned. The appearance of the lymph node will depend on whether or not it is a lymphoma, so a cancer of the lymph nodes, or it's a metastasis, so it's spread from a primary tumour, prostate, breast, lung, whatever it might be, into the nearby lymph nodes or the distant lymph nodes. When we're looking at MRI, obviously we have different weightings. For the purpose of this talk, on a T1 image, the lymph node will look similar in intensity to muscle, so not particularly bright on T1. On T2, they're slightly brighter, so there's a hyper intense signal. Again, nothing to write home about, but they will look slightly more hyper intense in the surrounding structures. And then on a diffusion weighted image, so that's an image that basically looks at the restriction of Brownian motion, so the restriction of water within the body. It will show us a brighter image on the DWI, which is a diffusion weighted image. It'll be hyper intense, so there'll be an area of increased signal. And then sometimes with DWI, diffusion weighted imaging, we get another picture that's associated with it called an ADC map, and it will look darker on that. Okay, so what you would need to know for the purposes of AFR2 would be that on MRI, a T1 image is similar signal density to muscle, so it's relatively low signal. On T2, it's slightly brighter, it's hyper intense signal. And then on DWI, which is diffusion weighted, is also hyper intense, so there's an area of brightness. So we'll have a wee look at an image. So this is a patient who has breast cancer in her right breast, although it's not as obvious on this diffusion because of just where the coils maybe are sitting or the slice that we're looking at. You can actually look at the analysis of the axilla on the right hand side. So I'll just get my pointer up again if I can. So you can see here, this is a diffusion weighted image, and you can see there's this area of restricted diffusion there, and it's showing hyper intense, so it's bright on the DWI. And when they actually measured this, it was about 20 millimeters, sitting within the right pectoralis minor muscle. Okay, so you can see it on the ADC map. So as I said, don't worry too much about ADC at the moment, but it's basically you know, an image that we get when we do diffusion, and you can see the same lymph node is enlarged here, and they've zoomed in a bit so you can see it a bit closer up, and it's dark on this image as well, so it's hypo-intense. On this image, this is a patient who's got cervical cancer, and it just really depicts how tricky it is to see the lymph nodes on MRI sometimes, especially if they're relatively small. So I'll show you, you can see it with the arrow there, but there is a left external iliac node just sitting in here. And this is on the T2 and the T1. You can see it here. Okay, so the T1, it's quite similar in terms of a signal to the surrounding muscles, and then on the T2 you can see that it's higher signal, so it's much more hyper intense. Okay, so we're going to look at lymph nodes on PET-CT, and really CT and PET-CT combined are quite good at imaging the lymph nodes, again, if they're abnormal. So you might see a theme, really, to really see the lymph nodes properly on an image, they have to be slightly enlarged, or you can see them when they're smaller, but they're not as obvious to find, okay? So the combination of PET and CT makes up PET-CT. It's quite self-explanatory. So it's essentially cross-sectional imaging which combines anatomic information that's provided by the CT and then the metabolic information that's provided by the positron emission tomography, which is the PET. It really is pivotal in terms of diagnosing cancer, assessing stages, looking at surveillance and monitoring, you know, therapy, because you're looking at images from both a kind of morphologic and anatomic perspective of the disease. Okay, so it gets us to, allows you to pick up on physical abnormalities or changes. The CT part will look at that, but then the PET part lets you look at the how the body is behaving and how the changes are behaving and how the cells are behaving, and that's a really important part of disease assessment. So essentially when you have a PET-CT, you're having both a CT scan and the positron emission tomography nuclear medicine scan. So you get this injection of a radioactive substance, and then your body uptakes that. And if you have areas of disease or malignancy, then you will have high areas of uptake. And then someone will appraise both the CT image and also the nuclear medicine image, and also they'll superimpose to give more information. Okay, so essentially it's a combination of CT and PET, and together it gives us both anatomical information and then also metabolic information as well. So that's a very basic overview of what PET-CT is. So one of the main cancers that we would use PET-CT for imaging would be lymphoma, and lymphoma basically is a name for a heterogeneous group of diseases that arise from your cells and your immune system. There's different types, so you might have heard of Hodgkin's lymphoma, non-Hodgkin's lymphoma, Burkitt's lymphoma, B-cell lymphoma, so there's lots of different types, and PET-CT can be used to stage them. The main advantage over, you know, just the anatomical imaging, which is the CT, is that with the PET part, we can detect metabolic changes before there's been any structural changes that are visible. So it can then detect more lesions in the CT and may lead to maybe earlier pickup of lesions, or, you know, detect a stage for the patient. And also it can pick up maybe occult lesions that might be in the spleen or in the bone marrow or in the gastrointestinal system. So on CT, a normal lymph node will be homogeneous, so similar to ultrasound. you'll see the fatty hilum, should be obvious, and usually again they're less than 1 centimetre. On CT, if it's abnormal, a lymph node will appear enlarged, so maybe bigger than 1 centimetre, and it'll lack the fatty hilum again, and then again it might enhance with contrast. On PET CT, you'll see if things are normal, you will just see the expected areas of uptake of the FDG radioactive material. But if your lymph nodes are abnormal, on PET CT, you'll see uptake in those lymph nodes, and then you'll also see it potentially in the bone marrow and the spleen if that's involved too. Okay, so this is a normal CT, and you can see that there is a lymph node the white arrow is pointing at, and if you look really, really closely, there's a little dark kind of circle in the middle, and that's the fatty hilum. So this is a normal benign lymph node that is slightly bigger. When they measured it, it was 9 millimeters, so it is starting to become, you know, enlarged, but there's no evidence based on this image that it's malignant. Okay, so we'll have a wee look at what a malignant one would look like. Okay, this is a patient who's got large B-cell lymphoma, and I'll just get my wee pointer to see if we can. Okay, so it shows that there's lots of different uptake. So in this CT, this axial CT, you can see that there's a large mass just here. And then you can see that the corresponding area of uptake on when they've superimposed the CT and the PET. So obviously these areas in yellow are areas of increased uptake. There's also axillary and abdominal lymphadenopathy. You can see them with the thin arrows here, and then the corresponding areas of uptake. You can see them here as well. Okay, and actually there's also areas of uptake in the pelvis as well. So this is spread to the bone marrow too. Okay, so there's lesions that are picked up on the CT, and then there's lesions that are much more easily seen when you have the combination of the PET and the CT together. So areas of uptake are always brighter on these images. All right, you can see obviously the mass up there. Okay, so this is another axial CT and then a PET CT image. This is a case of non-Hodgkin's lymphoma, and you can see there's bulky areas of lymphadenopathy with some bowel involvement as well. So on the CT scan, you can see that it's just slightly darker than the surrounding structures, but it's much more obvious on the PET CT scan. There's this area of increased uptake. And also you can see here, this is actually the bowel, and there's some areas of uptake in the bowel as well. Another axial CT in a patient with lymphoma, and there is some retroperitoneal lymphadenopathy. You can see that in the thin arrows here on the CT. But again, to the trained eye, I'm sure this is quite obvious, but you know, to us who are not so trained in CT, we're not radiologists, actually it's not as obvious, but when you see the increased area of uptake on the PET CT and the corresponds with the CT image, it's just so much more obvious. And there's also some areas of uptake as well in lymph nodes just around the retroperitoneal area. Okay, and this axial image here shows you that on the CT it looks fairly normal and maybe not concerning, but you can see actually from the corresponding PET CT image that there is increased areas of uptake within the proximal right femur and the shaft, which is suggestive of bone marrow involvement. And lastly here you can see the 41-year-old woman, she's got breast cancer, and the PET CT scan shows increased uptake in the right posterior cervical lymph node. And if you see it on the CT scan, it looks quite small and nondescript, and actually on this particular woman, this was missed on the CT and they needed the PET part to diagnose the fact that she had cervical lymph node involvement. Okay, and on this final image, you'll see that there is bilateral para-aortic nodes, and you can only really see them unilaterally on the CT, but you can see on the PET CT that they're very obvious. Okay, so that just shows you really the benefit of having the combination of both the PET scan and the CT scan to confirm lymph node and lymphoma, essentially. So that's really a brief overview of lymph nodes on imaging. As I said, it's very much focused on the abnormal as opposed to the normal, just because of the nature of lymph nodes. So thank you for watching, and I'll see you at the tutorial.